Hey,
I'll
Joe,
see if I can't find it.
Joe, I got to say something about the Cleveland Clinic.
Please.
I was very pleased. I was very pleased to see this topic today because about a year ago, I was an expert witness in Cleveland for the Cleveland Clinic who was being sued by a company, a device company, who said that the Cleveland Clinic had not lived up to their obligations to develop the device component of their combination device. That I think it was actually I think it was an LVAD pump. But anyway, bottom line was, I testified that the institution like the Cleveland Clinic should never be expected to have the infrastructure necessary to actually develop a product. They are an idea source, and they can determine the clinical needs and come up with a concept that will meet the clinical needs. But if you don't expect them to hire design engineers and pick out materials and set up manufacturing, they're not going to do that. Well, the interesting story was that this was actually a hearing, and it was like a court. There was a judge and an opposing attorney. And when I came out, there were two gentlemen standing there, and they said, "Mr. Stevens, we're lawyers for the Cleveland Clinic." They weren't the lawyer that hired me. It was a private attorney that hired me. And I said, "Okay." And so we were in the hearing room there, and we saw you testify. And I said, "Yeah." And this is what he said: "Is you're not like those other expert witnesses." And I got worried. I thought, "Oh God, what did I do?" And then I said, "Well, in what sense?" And he says, "Well, you didn't seem nervous." He said, "The other expert witnesses that we've had, when they get in there on the stand and are being questioned by the attorney and by the judge, they tend to hem and haw and stammer." And I said, "Really?" I said, "That's not me. I just go in and talk." He said, "Yeah, you just had a conversation with the judge and the other attorney." And I said, "Well, yeah, that's the way I am." Well, the attorney that hired me was very pleased, and he said, "If I ever need another FDA expert witness, I'm going to hire you because you come off so well in there." And I said, so I got wonderful memories of the Cleveland Clinic. Oh, and by the way, Cleveland Clinic won the case. They were not held responsible for developing the manufacturability of the device. So anyway, thank you for letting me tell that story.
Well, as you can see, JD, I'll let anyone talk on these things.
So Larry, I think I know which company you're referring to. I've heard the stories, although I wasn't involved myself.
Oh.
How
long ago was this?
Oh, it was over a year ago. So certainly within 2 years, yeah.
So does the name Cleveland Heart sound familiar?
Yeah, that was the company within the Cleveland Clinic, yeah. Yep.
Yeah, so if you come to Cleveland and buy me a drink, I'll tell you the whole story.
I'll remember that. Actually,
what about the rest of us? Come on, John. What about the rest of us?
Well, anyone who's willing to come to Cleveland and buy me a drink, I'll tell you a story.
Anything for a drink.
First of all, coming to Cleveland is a feat in and of itself.
But I have some tender hearts. Cleveland. I was born there in April of 1948 at the main hospital in Cleveland, and so I'm a Buckeye by birth.
Oh, awesome!
But my dad moved us to California, and that's where I lived until 12 years ago when I moved to the Midwest. But good memories of Cleveland from my birth.
So I'm sitting right, even though I'm on a virtual background, I actually do sit right on the main campus. So I'm probably a 5-minute walk from where you were born.
There you go.
Is your view far less?
It's
impressive?
far less exotic than what's behind me. But yeah, I look at a parking garage basically. But behind the parking garage is a really cool looking building.
I have to say, well, first, Eddie Capabianca, you've probably never met John before. What you both share in common is your Wharton Follies alumni.
Oh.
Eddie was
guessing you
the
came
class
after
of
me because you have
91.
less. Yeah. Oh, okay. All right. I'm impressed.
Eddie was the class of 91 and John's the class of 94. And I'm the class of 94.
Oh, yeah. And
I
I was
more
on
gray hair than
stage
you,
with
so.
Joe.
I never shared the stage with John, except they named his character after one of my characters. So we both played Professor Cash, even though they took different iterations.
So we're like the two main characters on Bewitched, basically, different characters.
That's right. We both played Darren.
Darren, yes.
But I was the first Darren, which people think it, well, anyhow, we don't need to get about it. I'll also say, I don't know what the D stands for. You use JD and John. Which one do you use professionally?
So when I came to Wharton, I was known as John David, which is pretty much how I've been known my whole life. I'm originally from the South, and we use all three names in the South. So I was John David for most of my life, and through my early professional career, when I met my wife, who is a native of Long Island, New York, all of her friends have one syllable name. So Deborah is Deb, and Stacy is Stace. And so when she met me, she's like, John David, that's like way too many syllables. So we compromised with JD. I shortened my name, and she got it down to 2 syllables, but not 1. So I've been known as JD professionally and personally for the last 25 years. But when you met me, I was John David.
I did not know that. The other thing is I have to thank you right off the bat. I'm seeing names on today's broadcast I haven't seen in more than a year. Stupplebean, where has he been? Weidenhammer, what's happening? So maybe they'll show their faces as well. And for those names, and there are many that I don't recognize at all, you'll see that the spirit of this event is kind of a free-for-all. So I invite you too, you strangers, to accept my invitation to be a panelist, just so we can see your faces. And if you have a question, you can ask JD, as he's known professionally, personally, and I don't have to intercede and read what Tom and William have to say. So there we are. By the way, Rick Stockton, have you been known as John Richard your whole life, being raised in the South?
Well, actually, I was raised in Minnesota and Boston and North Jersey. So I didn't discover that Texas existed until I was 17.
They don't have history where you were raised? They didn't know geography, none of that?
Well, I knew it was this big state, one of many big states among a bunch of square states. And but mostly my geography was limited to figuring out how to draw North Dakota. That was really hard. And South Dakota, 2 squares. Minnesota was harder. And then Boston was
a long way.
Totally different.
Why do you draw for a living?
Yes, I do.
Yes, he does. He does design for manufacturability, which would have been helpful in the Cleveland Clinic case, it sounds like.
Possibly.
JD, tell us where you were before where you are.
Yep. So I've been at Cleveland Clinic now for almost 2 years. And I moved to Cleveland about 3 months after starting here full time. Prior to that, I was in New York City, the greater New York City area, for about 25 years. Out of Wharton, I joined the investment banking field for about 20 years with a specific focus on medtech, private capital raising, and medtech M&A. Spent most of my career on Wall Street at Wasserstein Perella, Lazard, and Rothschild in various levels of seniority, focusing on medtech and healthcare. I left banking in 2014 to join a company called Henry Schein, which is located on Long Island. And I ran business development for Henry Schein's tiny $1.5 billion medical division, which was the ugly red-headed stepchild of Henry Schein at the time. And over a 2-year period, we grew that business by about 60%. When I left 2 years later, it was a $2.5 billion division, and is now one of the 2 divisions at Henry Schein, because right around the time that I left, they were in the process of spinning off the animal health division. And then from there, I went to work at a independent sponsor called Pulse Equity Partners, focused on healthcare. So it was investing in growth stage healthcare services and healthcare technology companies. And I had an operating role there until I joined Cleveland Clinic back in 2021.
So the answer to the folks' question, I'm sure, is yes, I've already asked him, and no, he can't make 10X this year.
True. Although I'm going to continue to work hard. Joe and I have had an ongoing dialogue about when am I going to show up at 10X. Unfortunately for me, Cleveland Clinic, like many hospitals, is not in a strong operating position. And because of that, we've had some severe constraints on our ability to travel, but it is on my bucket list. And when I say bucket list, I mean in the next 12 to 18 months.
Do you have some condition we need to know about?
Yeah, it's called fear of missing out of 10X.
That's funny. I may have to use that. There's a chance Teitelbaum will show up today. I've been trying to get him to give a talk as well, but you might be the lure. You're the clickbait.
Yeah, so if I can scare him into doing something, I'm happy to do that.
Please do. Take us away. You said you prepared some slides, although I'm sure you could entertain us and regale us with stories without any slides.
And in true corporate fashion, I have some very formal slides I'll walk you guys through, but you would like this to be as open a dialogue as possible. So feel free to interrupt or ask questions, whatever everybody like.
We're trained to.
You can see my screen?
We can.
Awesome. All right, away we go. So what is corporate venture capital? I think everybody on this call probably understands corporate venture capital, but we've seen an explosion in the last 10 years. I just learned Chipotle started a venture capital arm as well. I'm not really sure what they're going to be investing in, but conceptually, the twin goals that any venture capital firm that's part of a corporate entity should be focused on is how do you blend an attractive risk-adjusted return on invested capital with the strategic priorities of the entity. Cleveland Clinic has its own flavor of corporate venture capital, which is very different than everybody else. I'm sure every corporate venture capital entity talks about that, but I wanted to just spend a couple of slides on why is corporate venture capital relevant in the broader spectrum of startups and development stage companies. So this is, I think, a really interesting slide, and this data comes from, I can't remember, so I think some of it comes from SVB and some of it comes from CB Insights, but you've seen a steady incline on the left-hand chart of the participation of corporate venture capital in funding rounds for development stage companies. That top line is what percentage of deals have a corporate VC as part of the raise, and then that lower, slightly darker purple line is what percentage of the round itself the corporate venture capital represents as the total amount of capital. So you've seen a steady incline. The other thing I think that we've all lived through over the last few years is 2021 was kind of an aberration in the capital raising field for venture capital. But if you kind of look at this long-term trend, corporate venture capital has become a more meaningful participant in rounds of venture capital raising, both from a participation level and from a percentage dollar raise standpoint. And then, where corporate venture capital tends to focus is on that early stage with I would say a tendency to focus on once there's some proof of concept or early clinical work to demonstrate the efficacy of a solution. That's typically when corporate venture capital jumps in. Cleveland Clinic's a little bit different, and I'll get into the whys and the wherefores of how we're different. I see there's a hand raised. David?
Hey, JD, thanks. So in my memory, Medtronic, as the company example I know, would always put, I don't know, a small amount of bucks into a small company with the right of refusal to prevent others from buying it. Is that included in this, or is this a wholly different category? Thanks.
No, that they would fall into that, but I think your point's well taken, David, and I probably should have mentioned this, but for a company like Medtronic is a great example, and J&J has an arm, and Abbott has an arm, and BD has an arm. All the big medtech companies typically have a venture arm. Boston Scientific also, and they want to do exactly what you're describing. They want to get an early look into something without committing a lot of capital. They want to sit in that boardroom and hear how it's progressing and what are the challenges, but they also want to negotiate certain strategic rights. And as a banker, I always advise my clients, don't. It's a terrible idea. The trend, I would say, over the last 10 years is you can likely get a strategic to invest as an entrepreneur without having to give up those rights. Those rights can severely limit your ability to exit, the price at which you exit, and the degree to which you can engage with anybody else. Sometimes just having Medtronic on your cap table could prevent Boston Scientific or Abbott from talking to you. But it's okay to take their money, just make sure that it's not restricted capital. It's not capital that comes with hooks into the company for it. And I think we've seen more of a willingness by the corporate venture capital companies in healthcare and in medtech in particular to put their money in now and to maybe try to negotiate a non-exclusive agreement apart from the investment. And if they don't, then you don't have to always play ball. Dave, you have a follow-up?
Can you give me please?
Yep.
Your definition of corporate venture capital as opposed to the Medtronic, J&J's, Boston, putting some seed money in?
Yeah, so I would argue all those guys are corporate venture capital. It's basically any corporate entity, for profit or not, private or public, who is using their own treasury money in some vehicle to acquire a minority equity stake or a security convertible into a minority equity stake into a business.
Okay.
They're buying majority, that's M&A.
Yeah, thanks.
Yep, no problem. And again, I probably should spend a little bit more time on the prior page, but see if I can go backwards. Again, lots of different flavors. Some have very structured funds, some have evergreen funds, some invest directly off the treasury, so they don't have a formal structure. Some of them will, make very small investments. Some will invest 49%. At Henry Schein, it was really important for us to consolidate. So we would typically want to buy 50% plus one share, and we don't mind having minority investors. We just want to be able to consolidate the earnings. So again, each corporate venture capital entity has a different role, purpose, and goals as part of what they're trying to do. But it's typically, I'm going to skip forward 2 slides. It really is the melding of these 2 concepts, strategic versus financial. And so this is actually a survey that was taken by Silicon Valley Bank. Sorry, I have to wave my arms because if I don't move around in my office, my light turns off. The survey was basically taken by a large participant level in the corporate venture capital world. So what are you trying to accomplish? Is it pure strategic? Is it pure financial? Or is it some hybrid? And you can see here that this was taken, I think, back in 2021, that most of the corporate venture capitalists are kind of focusing on that middle. So you're trying to balance getting good ROIC. So we're not flushing money down the toilet just to get a small equity stake in a business. On the other side, we're not investing in something that has no strategic relevance to us just to make a good ROIC. It's really a combination of where that intersection of this is in our sweet spot. This is where we as a strategic think we can add value as a board member and as a partner to the company. And we can also get our 10x return, at the end of the day. So I'm going to, because this is about how Cleveland Clinic approaches venture capital. We're going to get to that in a moment, but I see, Rick, you have a question.
Yes, one thing that I'll be looking for throughout this presentation is I provide a technical service, but usually I'm one step away from the investors. In other words, I'll be working for the CEO of a small firm. That person, of course, will very often need to acquire investment money. And so my question is, what are the forms of analysis that will be easiest for my client to turn into presentation material for the people who might invest in his company?
So Rick, I actually have a slide on that, and I did not preview this. You're not a plant to this audience, but I'm going to go through the criteria that, frankly, that we look at when we kind of evaluate. So, and again, I won't preview it too much, but we do a quick screen and we look for red flags, and then we do a deep dive into 14 discrete criteria that we look at to qualify what makes sense for us to pursue. Or, hey, this isn't resolved yet. Let's put the investment opportunity on hold until that gets resolved. Or this is a red flag. The market's not big enough. The management's terrible. $80 million is gone in the company already. There's no way for us to ever get a return here. That I would call the true red flag, where we're going to stop doing work. I think that answers your question, correct?
Yeah. The only way that I could probably be more specific, and I'm just kind of doing this on the fly, because I am not a plant, is if I'm working, if I get a design and I can work $30,000 or $40,000 of cost reduction into it, what I'm going to be looking for and concentrating on and trying to absorb from your presentation is what are the things that I can give to my customers and in what format, so that they won't have to do a whole ton of stuff to turn around and enter that as one element of the presentation.
Yes.
To their hopeful funders.
So I have 2 slides that will cover that. One's the criteria, and then kind of what the work that we do to evaluate it. But I probably don't have like sample slides of like what a company would want to show to an investor to address it. But if they know the criteria, you can find someone who spent 6 months in investment banking that can help develop a slide on, okay, how do we address market size? How do we address the patent portfolio? Things like that. So
thanks, I appreciate that.
No problem. Great. I'm assuming everybody on this slide on this call has heard of Cleveland Clinic or knows about Cleveland Clinic, but I thought I'd just cite a few statistics about Cleveland Clinic as a whole. I frankly didn't know about all of these until I joined Cleveland Clinic. So we see over 3 million unique patients a year across our hospitals in Northeast Ohio, South Florida. We have facilities in Las Vegas, Toronto, Abu Dhabi, and then we just opened a fairly significant facility right in the heart of London, a 5-minute walk from Buckingham Palace. So we are truly a global enterprise. We have 77,000 caregivers across our network who are employees of Cleveland Clinic. And then of those 77,000 care workers, because I count as a care worker even though I don't see patients, we have about 18,000 RNs and advanced practice providers, and then 5,000 physicians and scientists who work at Cleveland Clinic. And so we have 10 million unique patient encounters on an outpatient basis as well. So we see a lot of volume, although if you know anything about Cleveland Clinic, we're typically seeing the sickest patients, and we're typically seeing patients with a very particular condition that requires expertise or has a level of rarity to it. So we actually see a pretty unique set of patients across our system as well. So I work in an organization called Cleveland Clinic Innovations, of which Ventures is a part, and you can see Ventures in kind of a red box here. But I thought it'd be helpful to just give an overview of like what is Cleveland Clinic Innovations and how do we work. So like any large academic institution, we are 77,000 caregivers are constantly discovering and inventing new things. We have a very large research institute called Lerner Research Institute here on campus. Our clinicians are constantly performing surgeries and thinking about ways, boy, if I had this tool, it sure would make my procedures a lot easier. So they're constantly thinking about ways to improve care and improve the way they operate. And so we get hundreds of what are called IDFs. If anyone's ever worked in an academic institution, you know what an IDF is. For those who don't, it's an abbreviation for an invention disclosure form, which basically discloses an aha moment. I have an idea. Here's my napkin sketch that I drew out, or here's my 72-page treatise on the product or solution that I want to develop, and I think it's a good idea. Why do they do that? Because according to their employment agreement, anything they invent or discover while they are a Cleveland Clinic employee is the property of Cleveland Clinic. So then why would they ever disclose it as opposed to just keeping it in their head and waiting until the day they are no longer a Cleveland Clinic employee and saying, aha? Well, the reason is if they submit it to Cleveland Clinic Innovations and we accept it, then Cleveland Clinic will spend the money to vet their idea, to develop and transform their idea into a body of intellectual property that can then either be licensed to a third party or around which we can build a new company. And in so doing, the inventor gets a contractual participation in the economics associated with that intellectual property. So Joe, if you're an inventor and you submit something to Cleveland Clinic and it's taken up, you will get a material minority share of any equity that results from your invention and the resulting license and any royalties associated with that license as well. So, and you can be as involved as you want to be going forward. You can be a consultant to the company. You can chat with us once a month about your invention. You could potentially leave the clinic and become an employee of the company. You could stay a Cleveland Clinic employee and become a member of the SAB or chief medical officer or chief scientific officer of the company as well. So there's a lot of flexibility that we offer our inventors and a clear pathway without having them to go around hunting up capital and putting their own money in the business to monetize their investments.
And JD, David, does that inventor stay on the IP, just the initial, or downstream as things are tweaked, as long as they stay involved, they're still on probably?
So they are, so Cleveland Clinic would be the owner of the IP. They would be a named inventor on the patent. And then they don't have to stay at Cleveland Clinic to get that economic participation.
Oh, thanks.
We have plenty of inventors who, one guy works at UCSF, one guy works at Moffitt, a number of folks are retired. They continue to collect their royalty checks and have their, call it shadow equity in the Cleveland Clinic stake in that business as a result. So it's a nice model. I think other entities do it as well. I think Mayo has a similar model. I know OSF has a similar model, but it's a great way for us to create real incentives for the generation of ideas. So unlike most venture investors, we're not, shortage of ideas and we're hunting for areas to look at. We probably have the opposite problem. We do, so I'll mention it now. About 75% of the companies in our portfolios are themselves licensees of Cleveland Clinic IP. We do look outside the clinic as well for ideas. Historically, we have not, which is why we're at 25% today. I've only been here a couple of years. I can only turn the ship so fast, but I think eventually we'd like to have a pretty even balance between internal and external sourced companies. So very quickly, we reorganized Cleveland Clinic Innovations around the time I joined into 5 discrete categories. I'll go through them very quickly. We have our engagement team. Think of them as our customer service department. They're working directly with our inventors to solicit ideas, to help the inventor polish the IDF, and then to report back to the inventor about how's it going and staying in touch with them regularly. That goes through an initial qualification. We have an assessment team that does everything from market sizing, competition, what the IP portfolio landscape is in the space. Is this an idea worth pursuing? They'll take that to our go no-go committee if it moves forward. We have an internal technology development team. Think of them as kind of our incubator group. They'll actually transform the idea into a prototype, a product, or a solution that a third party can then evaluate as a potential license opportunity. Then it goes into our BD and partnership. Think of that as kind of our commercialization team. We have a licensing team that will negotiate licenses with third parties. And then the ventures team will identify IP that we have that could be a new co. We will work in partnership with the technology development and licensing. On the rare occasion, 2 or 3 times a year, we might start up a new company, license the IP exclusively from Cleveland Clinic to that company that we form. We will capitalize that business. We will serve as board members for that business. We will hire management to run the business, and then we will work with management to develop and then execute on a strategy to achieve success. So this is something I mentioned before. We have kind of a 3-step process. We have 14 criteria. I think I have a slide here on what the 14 criteria are, but in case I don't, it really runs the gamut from the management team, IP, what's the market size, what's the competitive dynamic look like, what does the buyer universe look like? You know, is it one buyer? And so we're screwed if we're like, if GE does want to buy this and they're the only game in town, do we really want to go down the pathway of operationalizing this company? What's the value proposition to the patient? What's the value proposition to the user or the provider? Let me see. Are there any legal issues outstanding? I think I've just named about 7 or 8 of the 14 criteria, but I do have another slide that kind of goes into some depth as to the work that we do. So we first just do an initial screen. Typically takes us about a week. We're really looking for red flags or reasons not to do any more work. And if there are no red flags, then we'll move forward, and then we'll do a deeper dive where we might spend 2, 4, 6, 8 weeks doing work, working with our clinical experts across the street, working with subject matter experts within and outside of Cleveland Clinic to really vet out each of those 14 criteria. And then we develop something that we call the scorecard. And I have a sample that I'm going to show you guys in a moment. Once we develop that scorecard, we use a really complicated color scheme. It's green, yellow, red. We code each of those 14 criteria as this looks good, there are some questions, or there's an issue. If we end up with a scorecard that's mostly red, we probably don't move forward. If it's mostly green, we'll typically recommend it to our investment committee as a new company. And if it's yellow, we probably have to do some more work. And so we might iterate it a few times before we get there.
How many companies get in front of you each year?
So in terms of inbound opportunities, we probably see 150 business plans or decks that we'll evaluate. And then in addition, we may have
year?
Sorry?
Per year?
Yeah. Just like someone sends me an email and says, can you look at this? And we'll look at it. Huh. We probably have another 150 that we don't have time to look at, or we immediately dismiss it before we even look at it.
I was thinking you'd have thousands in front of you a year.
Right. So that's inbound opportunities from the outside. Then on top of that, we get about 300 new IDFs submitted by Cleveland Clinic employees every year. And that I'm a Wharton guy, right? So it's stocks and flows. So we operationalize about between 50 and 75 new licenses a year, and we will start anywhere from 1 to 3 new companies a year. So the good news for all you entrepreneurs is the hit rate internally is no better than the hit rate externally. It's still a little bit of a long shot to get from I have an idea to I have a company. Mm-hmm. But we're definitely heavily and favorably informed by our clinical experts across the street. And I love to tell everybody, every investor says they're a value-added investor. We are really a value-added investor. And why? Because I have the top neurologist in the world sitting a quarter mile from me. I have the top cardiothoracic surgeon who is a speed dial away from me. I have the top interventional cardiologist who is a 4-minute walk from me. And we can get in front of those folks and get their opinion, not just, hey, is this a good idea? Does it work? But it's within the context of those folks who are involved in clinical studies with every medical device in their field out there. Our cardiothoracic surgeon is working on studies with Abbott, with Edwards, with Medtronic. They see everything, and they have an incredibly well-informed view. Maybe the one handicap we have is because we see the sickest patients, where we probably struggle a little bit with is, well, this could serve 80% of the cardiovascular market. Well, we don't know what to do with that because we only see the 10% that's the sickest. So then I got to call our contacts at NYP or Cedars-Sinai or some other hospital where they maybe could give us a little bit more informed view of the less sick patients. And then, of course, once we do engage with a company, we can bring a lot of resources to bear. Of course, we have capital, but I would argue that is the most fungible asset that we bring to the table. We also bring clinical expertise, early adoption, the ability to run a study, to bring a PI who is a world-renowned clinician in the chosen field, to be a clinical site here at Cleveland Clinic, to be a beta site, to be an early adopter, to have one of our folks stand up on a podium and talk about a peer-reviewed study that was just completed with the Cleveland Clinic. Those are all really, really powerful assets that create value at our companies. And in my mind, the capital is just the icing on the cake. Although it's probably the most important thing for the entrepreneur, it's the icing on the cake for us.
Mm-hmm. I hear you.
So once we complete that scorecard, then we take it. We have a number of internal resources that we use. We have something called the NewCo strategy team, which is comprised of our leaders within innovations, but we also pull in some senior folks from strategy at Cleveland Clinic to evaluate our recommendations. We also have an external advisory council comprised of entrepreneurs, healthcare executives, and partners at venture capital firms who will look at some of our IP and some of the companies we're thinking about forming, and will weigh in based on their expertise and their interest as to, hey, JD, you guys really have something here, or stop wasting your time, you should just license this out. Once we get that feedback, we'll make it then a decision to take an investment opportunity to our investment committee, which is comprised of 4 senior leaders at Cleveland Clinic, our CFO, our Chief Research and Academic Officer, our Chief Strategy Officer, and our Deputy Chief Legal Officer. And they ultimately make the decisions about what we're investing in. We'll make a recommendation, but they're the ones that approve our investments. So one of the biggest questions we tend to ask, particularly for the internal projects, is, well, what's a license versus a new company? And you can see here, there's a number of criteria. Nothing's really hard and fast, but I think if we look at a technology, it's not a platform. It focuses on a very narrow subset. It's early relative from a demonstration of efficacy and feasibility standpoint. It's a small market from a dollar and from a prevalency standpoint. The growth rate is small. That sounds like a license. If it's a platform, it's a multi-billion-dollar opportunity targeting a very large target market that's going to significantly change the way a procedure is operated, or way a disease is treated. That sounds more like a company. So this is what our scorecard looks like. And I think 1, 2, 3, 4, 5, 6, 7, 8 of the 14 are listed on this page. So this is actually a company that we did work on. I don't think there's anything in here that discloses the company, but you can see we look at market opportunity, competitive structure, exit opportunities, clinical need, like I said, value prop for patients, value prop for payers and providers, clinical and regulatory, IP, legal matters, business and financial plan. I know what's not on here is management, which is really, really important. But you can see on this one, okay, there's a little bit of green, but a lot of yellow and some red. Probably not a company that's going to make it in terms of a recommendation. That's what happened with this company. We took more of a wait and see attitude with them. But this is a really good tool that we use to identify what the issues are, and then how we resolve them and who we talk to.
Who's doing that evaluation? You typically?
It's the ventures team that's doing the work, but we'll typically pull in folks from across innovation, and then of course we'll interview clinical and other experts both inside and outside of Cleveland Clinic.
How many folks are on that team?
So we have today 3 partners. We're going to be adding a 4th partner. We have 2 directors, and we're hiring, by the way. We are looking for 1 more partner, and we have a job posting up that I think I put on LinkedIn, and then we're looking to hire 2 associates in our group as well. We have 1 associate right now. So right now it's 7 people. We're looking to build up to 10.
I don't know if we have anyone on this call who would be a suitable candidate, but if so.
If you know of anybody, also feel free to send them our way.
Sure.
For associates, if you have any relatives, nephews, children, friends who have children who are 1 to 3 years out of school, have good financial background, love working in Excel, we'd love to talk to them. For the partners, we're looking for people with prior venture capital experience who love everything I've said so far about working in a corporate venture capital environment, which is certainly not everybody. So what I love to tell our investment committee, and everybody else will listen, is, for a lot of companies, when I was a banker, we raise money for a company, that's it, I'm done, give me my fee. That's when the real work actually starts. And so here at Cleveland Clinic, it's the same for us. We have our quarterly reports that we put together for our investment committee. We're serving on quarterly boards. I have weekly calls for all of our majority-owned businesses. I connect every week with each of our CEOs just to check in with them, make sure they have what they need, helping them work through issues, make introductions to investors, make introductions to strategics and the like. So we're very involved with each of our portfolio companies. And then we're continuing to add to the structure that we have around our reporting, what we call our KPIs, our key performance indicators, to make sure that we are measuring all the other criteria that feed into the ultimate thing we're measured on, which is what are our returns. Sorry, I gotta wave my hands again. I didn't time that, but it's like a nice little 15-minute break between my little treatises here. So
I'll put on a timer and we'll all wave with you next time.
Perfect. So this is really about systems. What are we doing right now? We're like everybody else, or a lot of other people, we use a CRM. We're trying to sort of track everything that's coming down the pike across innovations that might be a new co. We're tracking our conversations with entrepreneurs, with companies, with strategics, with investors to make sure we're following things up and making sure that we're organized and thoughtful so that the left hand knows what the right hand is doing, which is probably the biggest problem in any large institution that we have. And then again, that scorecard is really the centerpiece for every investment decision that we make. This is not something that was always the case, but since I took over as head of ventures here, I said, hey, we're doing a scorecard for every new company. We need to do it for every new investment, including companies already in our portfolio. We need to reanalyze all the things we liked before. Do we still like them with the new information? Are we still prepared to make another decision to invest more money in the company? And if there's a change in thinking, I don't want to just put more money in the company because we have some in there and we don't want to look stupid by getting diluted down. That may be the best possible thing for us. If we can no longer support the solution, we need to know that. So we sort of instituted this discipline of reevaluating some of the criteria that were the basis for our original investment. As I mentioned before, we put these quarterly investment reports together. And again, as I mentioned before, realized returns are the ultimate goal here. So we're looking at peer performance characteristics to make sure we're performing at or above our peer group. But then I think, Joe, to your earlier question, there's that huge top of the funnel, the IDFs that come in, and then a smaller number of licenses, and then a very, very small number of new companies that are produced out of our internal process. So I thought we could talk about like one specific portfolio company that followed that process. And I'll try to give a little background on the company itself. I'll try not to sell the company to all you guys, although I have a tendency to do that because I get excited about some of our really innovative companies. And I'll talk a little bit about how we went from this being an IDF to this being a body of IP to this being a company that Cleveland Clinic owned 100% of. We are now a minority owner of the company. I'll kind of get to the journey that this company went through to where they find themselves today, which is a revenue generating clinical solution in the OR at Cleveland Clinic and at other leading institutions. So just to give a background, Roy Greenberg was actually the vascular surgeon who came up with the IP. The basis of the intellectual property was he was a vascular surgeon, so he did a lot of cath lab work, so he was constantly using fluoroscopy, so he was constantly exposed to the deleterious effects of fluoroscopy. Sadly, he passed away a few years ago because of complications related to fluoroscopy exposure, but his vision was, why are we using so much fluoroscopy in the cath lab? There's got to be a better way to visualize where I am in the cardiovascular system of my patient. Where am I in the heart without using fluoroscopy? Oh, and by the way, in order to do my job effectively, I'm looking at a two-dimensional screen over here on my left, which is the fluoroscope, and I'm looking at a two-dimensional screen over here on the right, which is my cardiac ultrasound, and I have to be a calculus wizard in my head to figure out where I am in 3 dimensions. And I'm using the one word you never want to hear in the cath lab, which is oops. So his brainchild was, can we use other technologies to reduce the use of fluoroscopy and to provide a really attractive way to visualize in real time and help that clinician know exactly where they are. Kind of think of it as GPS for the human body in 3 dimensions. So this is what a clinician is typically used to looking at today. This is a spinal surgeon who's looking down at this patient's spine, and they're looking at contrast dye, they're looking at 2D, they're looking at low quality, they're looking at long exposure times, and oftentimes because you're looking at things in 2 dimension or trying to triangulate between two-dimensional images, things don't end up in the right place, procedures take longer, revision surgeries are required. This is what the patient sees with, what the clinician sees with Centerline. So this is a 3D real-time rendered image while the clinician is utilizing a catheter in the patient's vasculature. You're getting real-time measurements. You have interactive real-time 3D tracking. You're able to rotate the image. There are certain steps and procedures that we have experienced using this technology, or I should say the clinician has experienced using this technology, that reduce the time from hours to minutes or even seconds. So I don't know how many of you are familiar with like getting to the tricuspid valve in the heart. At one point, you have to come in through the mitral valve, and you have to do like a 180-degree turn in space to get to the tricuspid. Extremely difficult. One of the many reasons why we don't have a FDA-cleared tricuspid transcatheter solution today, which by the way, we're working on. And that's not entirely true. We don't have a replacement solution that's FDA approved today. We do obviously have repair solutions, but it's a very tricky turn. We had a patient where this was being attempted, and literally the clinician spent over an hour trying to get to the right spot and the right placement. Couldn't do it, pulled out. The next time the patient was in there, they used the centerline, and he was able to perform that step in the procedure in under 3 minutes. So a real game changer with respect to getting the right information for the patient and the clinician at the right time, and again, minimizing that exposure while getting the best information possible. By the way, this is one of the themes that we look at Cleveland Clinic Ventures, something I can't come up with a better set of language for it, but I call it surgical visualization and navigation. Another term might be the 21st century OR. There's tons of technology that the clinician should have access to in real time, but they're still using technology from the 90s, from the 80s, and even earlier. And I think we're going to look back at the early 2000s in the OR and wonder how we got away with such a barbaric set of tools that we give the clinician who is trying to perform these minimally invasive or transcatheter procedures with very, very bad visual information. So we've got other companies that we're working on in the space, but centerline is something obviously we're very excited about. So the exciting thing about this, I mentioned before, is this a product or a platform? Well, from our perspective, it's a platform. Today, we have a clearance by the FDA for centerline in the treatment of AAA. That's an EVAR solution that's FDA cleared. We have a current development roadmap to use the same technology in structural heart, in peripheral vascular, and in neurovascular. And then in the future, we plan to use this technology in a diagnostic radiology application for oncology. And we also believe that this can very much assist that huge swath of surgical robots that have been implanted that are being used for about 3% of their potential in the OR across the US. In fact, that's a whole nother conversation we can have about surgical robots, and the world doesn't need another surgical robot. We just need more clinicians to get comfortable with it and more procedures to use surgical robots for. And we think that this kind of visualization capability can help adapt that market. And in each of these areas, you can see on the left-hand side, we have a clinician across the street or a group of clinicians who is supporting the evolution of the solution across each of these disciplines. And we're lucky enough to have these different institutes at Cleveland Clinic with the appropriate level of expertise to help drive that the solution there. So maybe the last thing I'll mention, as I mentioned, we started this company as a Cleveland Clinic entity. We were able to, based on the company's progress, we were able to, along the way, bring in Jobs Ohio, which is a state-funded partner of ours. They invest in a number of our businesses, but it's a independent venture firm funded in large part by the state of Ohio. Jumpstart Ventures, which also gets state funding, but they're a for-profit venture firm. And then RIK Enterprises, which is a family office who has invested with us in a number of companies. But I think back to an earlier question, in the most recent round of funding, which was announced about a year ago, GE Healthcare was a big investor. And it won't surprise you to hear that they wanted rights of first refusal and they wanted exclusivity on certain of the applications. Well, guess what? They got none of that. So they're an investor, they're on the cap table, they have a board seat, and that's it. And from my perspective, from my selfish perspective, that's about as far as I would ever want to go with a what I would call a for-profit corporate venture investor, corporate venture capital entity. Ascension is which is a venture arm of Ascension Ventures is a venture arm of Ascension Health Ventures. They're like us. They're a venture arm of a non-for-profit healthcare institution. I have no problem with them on the cap table. I have no problem with Mayo Clinic Ventures being a member of our cap table. JJDC, different matter. GE, different matter. Medtronic, different matter. Abbott, different matter. We really want to make sure that our portfolio companies stay honest and keep that potential value of the company 100% available to us as an investor in the company. And I think, at least in this instance, we successfully argued with GE that they should want that too as an investor. And if they do decide in the future to buy the business, they should pay a fair price. The best way to get them to pay a fair price is not give them any proprietary rights that Siemens, Philips, Toshiba, Fuji, or anybody else who's a direct competitor of GE doesn't have. So I think that's my last slide. Happy to take any questions about how we operate, what we look at, what we're excited about. I mentioned surgical visualization and navigation as kind of being a power alley for us in MedTech. While I'm talking, which is always difficult to get me to stop talking, I'll just mention our two other power alleys, which is just where a majority of our ideas and companies come from. Structural heart is an area where we're very active. We have multiple companies that are around this concept of using a transcatheter approach to replace or repair a valve in the heart. There's a lot of innovation happening in the space, and Cleveland Clinic happens to be at the center of a lot of it. And then the third area where we're very active is in the area of neurostimulation. We're working on a number of projects and have a number of companies where we're using an electrical impulse to stimulate a therapeutic response, whether it's in the deep brain for stroke, whether it's in the hypoglossal nerve for OSA, or whether we're looking to stimulate the hearts of ADHF patients whose hearts have remodeled to improve their, really to break that cycle of acute decompensation in congestive heart failure patients.
Daniel Shepard, I'm confident you have something to
Well, I really appreciate that overview, JD. That was great to kind of understand the inner workings of how you guys operate, really detailed. I mean, I kind of have a two-part question for you. One's kind of on the inbound, one's on the outbound.
What you do.
Oh, yeah, I work for MedWorld Advisors. We do M&A advisory for healthcare companies. So we primarily do sell-side advisories for company in med device, med tech, digital health space.
Okay.
Yeah. So when you're
in past life, that was me, by the way.
I totally understand that you get it. Yep. When you're thinking about like your proprietary, kind of your inbound opportunities for stuff that doesn't come from the Cleveland Clinic, where do you usually see those come from? Are you do you have proprietary deal flow that you're looking for those? Do you solicit from bankers those types of opportunities? And how do you view that? And then also just a follow-up question on your outbound. So like what's your typical hold period for companies in your investment portfolio? When do you think about an exit? Is there a time frame? Are you waiting for that offer you can't refuse? Or is it like, okay, we've had this for 5 to 7 years. It's time to turn a profit on this?
So let me answer the second part of your question first, or your second question first, because it's pretty easy. Although you're probably going to hate the answer. The answer is it depends. Because we are not a formal fund structure, we don't have an expiration date on our capital. We're investing directly off of Cleveland Clinic's balance sheet. So we have the flexibility to hold for as long as we feel we can justify continuing to hold the investment. Ultimately, unlike most corporate VCs, I didn't mention this before, but I think it's really interesting. I sat on a panel back in January at the Resi conference in San Francisco, and I was on the panel with 4 other corporate VCs, and I was the last person on the panel. The first 4 talked about, oh, we want to make like a 3 or 5% investment in a company and then get to 19.9 and then acquire the business. And it dawned on me, wow, I'm the only person on this panel where we typically start for our own companies, where we start them, we start at 100%, and we want to go to 0 eventually, whereas everybody else is the opposite. So we're looking for a good exit. We don't mind getting diluted down to 25 or 20 or 15% if we're bringing in the right investor partners, whether it's VCs, corporates, or other. And then eventually we do want to monetize the investment. But we really have 3 goals, to be honest, and they're kind of intertwined. Number 1, we want to get a good ROIC, so 10x. Number 2, see, that's a plug for you, Joe, by the way, again, second time I've done that. Number 2, we want to monetize our ownership in the IP. So if we're starting a company, it's because we believe we have the best shot at de-risking it to the point that we can find a buyer or an investor to work with us or to buy the asset from us. But we want to get a good return on that IP, and we love the idea that the company gets sold. And by the way, we still collect our royalty checks because we still own the IP, but the company that was acquired has the exclusive license. And then thirdly, we want to provide monetary compensation. Actually, this is part 2B. We want to provide similar monetary compensation to the inventor who gets their share of the royalties and their share of the equity based on their invention. And the third thing, and this is going to sound all sappy, but it's true. We are a non-for-profit institution who is trying to advance medicine. And so if at the end of the day, we don't get 10x, but we only get 3x, but we've completely changed how procedures are performed in the cath lab or access to healthcare, then we've achieved our mission. We are an innovative institution, and improving healthcare is part of our mission. Joe, you're talking, but you're on mute.
Thank you. Before I give you the next question, could everyone just take a moment to wave your hands? His light's about to go out. Thank you.
All right, thank you, everybody. And Daniel, you had a first part of your question too, and I forgot what I think it was interactions with bankers and outbound.
Your inbound deal flow for investments you look at.
Yeah. So historically, we've been kind of an inside-out investor. If we went in a time machine and went back 10 years, we might have 100% of our portfolio is Cleveland Clinic licensees. Today, it's about 75%. We are turning the ship. I'd say most of the team who's part of the ventures team today has joined since I joined. And so we all came here because we like the portfolio that Cleveland Clinic has built in ventures, but we also like the idea of balancing our internally generated companies with really exciting companies that Cleveland Clinic did not invent the IP for, but are strategically, clinically, and from an investment standpoint, important and attractive to Cleveland Clinic. So we're looking to continue to expand our influence in those areas. I'd say the easiest set of opportunities are those power alleys I discussed, structural heart, neurostimulation, and surgical visualization and navigation. We'll look at anything. If there's a company that isn't necessarily an investment fit yet, but resonates with one of our clinical institutes. So if you show me an idea in urology, I can have Jihad Kayuk or Andy Altman or what's the third guy? Goldstein. I can't remember his first name. I think it's David Goldstein. One of our senior urologists look at it and they could say, yeah, this is terrible, or this is interesting, but I need to see A, B, and C first. Or, oh, they're doing a clinical study. We would love to be a site. Who do I talk to about us participating in their clinical study? If I get that clinical champion, if I can identify and get that person excited about a company, then my chances of taking it forward and getting a recommendation to the investment committee and getting approval for us to participate are demonstrably higher. If I can't find that clinical champion, it's probably a dead end for us.
JD, do I lose you at the top of the hour? Because I have a half dozen folks.
Let me just look. I do have a call. I can probably be 5 minutes late too. How about that?
I accept.
7, 8 more minutes.
I'd love for Caitlin Morse to accept the invite to show up as a panelist. And I want Ross, please, to come off mute and tell JD what you do, because I think your tool could be immensely helpful.
Yeah, I was just wondering about that. So Ross Meisner with Basal Systems, and we take all of the public regulatory and quality data and make it easy and fast to research, get insights out of it. So what we're doing is supporting med tech companies, consulting firms, and investors to understand if there's quality trends, quality signals emerging, monitor, react, predict to these kinds of things. And so literally one of my colleagues, Mike, was just here asking me, is there, a potential need in an organization like yours?
I want to make sure I understood the question properly. I apologize.
He has a tool that makes it easier to search FDA, MAUD, CER reports, post-market surveillance, every recall, every warning letter than you could ever do with FDA-related sites. And he has an algorithm that actually, it's the way I think of it. FDA has way more information in it than you can extract, because the brain has it, but the interface isn't sophisticated enough to extract it. But he is like the Matrix, and he's plugged right into it. So you get better data faster.
Ask for a demo, JD.
So I'm going to ask my, send me an email. I'll put my email into the chat for anybody who wants to reach out to me. I'll probably ask Linda Lee, who just joined us in December as our digital health partner. This probably, she kind of sits in that space between medical devices and digital health. And this sounds like something that's right up her alley for her to evaluate.
Yeah, I would suggest we're usually used for two applications.
Sorry, go ahead.
I'd say we're usually used for two applications: the technology development, due diligence, competitive intelligence side, because you can quickly see what technologies, what products, what companies are active in a space because of the way we just make it easy to explore a landscape of related technologies. And then if people are monitoring the quality surveillance side. So those are the two big functional areas.
Ross is going to be at 10X. He's one of the sponsors. He doesn't have a formal workshop, but if you come early enough on Tuesday, he can give you a demo. JD's email is friedlj3@ccf.org. And I think you need that if you attempt to connect with him on LinkedIn. And Eddie Lee Stein has a question ahead of you. Lee is on mute.
Thanks for the great presentation. I was curious, what other medical institutions do you co-invest with? I'm actively involved with UCSD Medical and the Science and Technology Board. We just launched a rather innovative, actually the launch party is in 2 weeks. But anyway, the question
Time precludes us, but Lee is kind of a big deal.
So today I can tell you we count as co-investors in our portfolio companies, Ascension Health Ventures, Mayo Clinic Ventures. We have IIA agreements with a number of other medical and academic institutions, including Washington University of St. Louis. We have a number of IIAs, it won't surprise you, with Case Western here in Cleveland. We will work with anyone, to be honest. And the partner that just joined us from San Diego and connected us to, I think, someone who you may know. I'll see if I can find the guy's name. But he's based in San Diego, and I think he has an affiliation with UCSD. I don't know if it's in the same.
I mean, we could do that offline. But
yeah, no
and do you provide equity for BARDA grants?
We that's a good, not out of our innovations office, but
because it seems pretty innovative when they give their grant, but finding that 30% equity is an odd thing for young companies to try to figure out how to do.
Correct. I mean, I'd say the closest thing I know we do is for some ideas, we'll allow the inventor and facilitate the formation of a company where Cleveland Clinic does not own a majority stake, which enables the company to apply for SBIR grants. I'm not aware of any recent companies or involvement where we've either granted or the company has received BARDA grants. I know NIH, VA, and DoD are probably and then SBIR are probably the four sources of grant money that our projects and our companies are really focused on.
We're trying to be efficient with our last 3 minutes. Lee, are you presenting next week?
I'll check with the scientists that I want to introduce, but yeah.
Okay, fine.
Actually, they are people that are in line to get BARDA grant.
Need to cut you off, Eddie, quickly.
Hi, JD. Real quick, I'm based in the UK. I was intrigued, and I had seen that you guys had opened in London. I've got a small urology device, and it is literally small urology device company, and we're moving into clinical study time. And I don't know if that's something I might be able to talk to your London-based colleagues about, or if I should reach out to you directly.
So I'd say for everybody who's trying to get to someone at Cleveland Clinic, one of the functions we do in performing innovations is we can be a connector. So we can help find the right person. London's in a bit of a weird situation because, again, it's only been in operation for a little over a year. We're still trying to formalize our IDF policy over there. It's different domicile in the United States, and different rules. They are Cleveland Clinic employees over there, but they're not part of the foundation. That's a for-profit hospital over there, so it's a different legal entity.
Sure.
But I'm actually having a call next Monday with Bernardo Perez Villa, who's our engagement partner for our London office, and I'm happy to. You send me something, and
I'll send you our deck. It describes things pretty well, and yeah, we can take it offline.
Thank you. With the last minute, I'd like to ask anyone that I don't personally know, that we haven't spoken with, just jot me a quick chat so I can know who you are and why you joined us today. Last question is Alex. If you come off mute, he wants to know how you work with accelerators. He runs medstarter.vc.
So the short answer is we kind of have an embedded accelerator in our organization. We're not averse to working with outside parties in cooperation or collaboration. If it's an idea that we're trying to translate into a product, it's more likely than not at the small scale, we're probably going to do a lot of that in-house. But I think we are always interested in finding areas of complementarity, if that's a word. If there's complementary IP or complementary fields of expertise where we can bring in outside parties. For a lot of our companies and technologies, we, of course, will work with CMOs and other third parties to help us on the design side and the early design work around, let's say, a delivery system or a device. If there are particular ideas that you're working with or projects or companies that might be a match for areas of interest or IP that we already have, perfect world is you're already working on something and we have some complementary IP that we can contribute and we can be part of the solution that we help you get a running start on.
Right. So thanks for that, JD. We have former collaborative project in AlertG,
Oh,
which
sure.
did a
We're
clinical
speaking
study
with them
you
next
guys.
week.
Actually, yeah, no, we replaced the CEO. Semler is amazing. I mean, you came from Musk, he ran their medical device program, but he's also a college buddy of mine, also a teak, like us.
Oh, awesome.
JD, you're welcome here anytime. This was a real treat. Really happy to see you, and let's
Great
not
to see
do
you
it.
too. I can't promise the next time I'm going to have as impressive a deck, or just might look very similar to the one I just showed you, but I'll do my
You don't need a
do what I
deck.
can.
I think we could probably fill an hour with questions and advice.
Awesome.
A polite round for our guests today.
Thank you for your time,
And,
everybody. It was a pleasure.
We'll have you back as soon as you'll have us.
Perfect.
Have a great week, everyone. Thank you so much. Bye now.
Great job, Joe.
Thank you. Bye.
Thanks all.